afternoon, and thank you very much, the OET team, for inviting me to come here. Of course, I know that most seems to be experts in communication, so I'm really not going to talk about, I'm going to talk about communication, but I'm basically trying to tell the healthcare providers' experience. I'm only going to tell about my experience in my day-to-day experience. Now, I put my topic as do what you like or like what you do. Because I think the story applies to anybody who is coming into a country to be practicing medicine in a different language. They probably was not what they really wanted to, but you end up finally doing it. Most of the people who come to another country to do medicine will say that you probably, at some stage you changed, but you really did not think about it. So whatever job that we do, we'll have to do it with a passion. If you don't do it like that, then you are likely to do too badly. When it comes to an exam, if you think the exam as an obstacle, then you try to hate it, then you will find it difficult in passing it. But if you think that it is something that is going to help you, then you will grab it, then you will like it. So that's basically, what I'm going to say is I'm going to say my story, how I had to like what I do, then do what I like. And also the story of passion and the success stories. Then communication in patient safety, the evidence and the repercussions, and my day-to-day experience. I want to tell about me a little bit. Again, it's a little bit of boasting, but mainly I'll give you the reasons. I'm from the Indian Ocean island, Sri Lanka. I'm a medical doctor for 28 years, consultant pediatricians for more than 20 years. I was trained in the UK too. In Sri Lanka, all the specialists in any specialty, they have to necessarily undergo an overseas component of training before they are both certified as a specialist. This is something that is not seen in many parts of the world. It is necessary. So 90% of us either go to UK or Australia, then some goes to a few other countries like Singapore and other places also. And so I was trained in the UK. I had to do the IELTS 3 years those days. I'm currently the president of the College of Paediatricians. I'm head of this Center for Clinical Management of Dengue and Dengue Hemorrhagic Fever, which I myself initiated. I'm also a member of the Board of Study, trainer and examiner in pediatrics for Postgraduate Institute of Medicine, University of Colombo. I'm a co-author of the WHO Zero Guideline in the Management of Dengue. I'm a senior Ashok Fellow of the Ashok Foundation of Boston, USA since 2012. I was awarded the Outstanding Asian Pediatrician Award by the Asia Pacific Pediatric Association in 2016. Now, but all this, I never wanted to become a doctor, right? This is where I ended up. I wanted to do maths. I hated bioscience. Until, during our school days, the system is when you're at the O-levels, you're supposed to bring a letter from your parents, whether you are going to the maths class or the bio class. Those who go to the maths class do engineering, those who go to the bio class. So I was to do maths, my sister was to do bioscience. We got a present from one of our uncles. I got a weight set to do with the weights. She got a dissecting set. I couldn't do anything with the weight set without the weighing scale. So I cut a cockroach to see from where the antenna comes at the cockroach using my sister's dissecting set. She got really angry about using her dissecting set, and we had a fight. And this happened to be the day before that we were asked to bring a letter. My father wanted me to become a doctor. I said, never, never. Then at the end of the fight, I ended up saying, she said, you cannot touch my dissecting set. You're doing maths. Then I said, no, I'm also going to do bioscience. And I asked my father to give me a letter. He gave a letter readily. Then I took it to the principal and gave it and went to the bioscience class. I remember after a week or two when they were teaching bioscience, I couldn't just tolerate it. The principal asked whether I got highest in maths in the qualifying exam. why I'm not doing bioscience. I was just thinking, we were small, right? I was thinking how to go and face my sister, and kept waiting in the bioscience class. 1 or 2 weeks later, I wanted to go back. The principal asked, I said no. Now I have to go back to the principal and tell him, no, I want to go back to the maths class. But every time I go to his office, he's with somebody. So I thought he will scold me in front of others. Then after about 2 weeks, it was too late. I remained in the bioscience class, and that's how I went to that stream. Then I had no choice but to like bioscience, which I developed bioscience, and then I ended up becoming a doctor. Then after I qualified, we all think about becoming a specialist. I wanted to do pathology. Then we were organizing a cricket match between the teachers and the staff, and I went to collect money from a professor of pediatrics. And the way that I presented it annoyed him. He asked me who I am, and I had to introduce him to me, and most people said that he's a nasty person. If you are annoyed, you will never pass pediatrics. We start pediatric lectures at the 4th year. I remember him coming, remembering my name, and asked me to come and sit in the front corner in the class. Now that he keeps asking me questions in pediatrics. Of course, the pediatric exam is at the final MBBS. I was mainly concentrating. We used to study the other subjects that are there for the exam. But I had no choice because he's trying to take me to task. I had to go to the pediatrics department, get the topics of the lectures, started reading pediatrics to answer him because he's now giving me trouble. After about 3 months, I answered him better than most other people. Then he told me, okay, you can now go and sit wherever you like. I remember the day that I was going to the third row, or the second row where I could see better, that I decided to do pediatrics. Because I studied pediatrics all this time. Right. Now, similarly, after I became a pediatrician, my interest was in pediatric neurology. I was the first to start video telemetry EEG in Sri Lanka in the pediatric setting. And then I happened to be at a hospital. Of course, we are all general pediatricians at a hospital in the Gampaha district, which are the very high incidence of dengue and high mortality rate for dengue. The Sri Lanka's mortality rate for dengue fever at that time in 2009 was 2.3% in the district that I worked, whereas it was 1% nationally. So as a result, normally when you have a thing like this, that they send people for training to countries like Thailand, where dengue is more prevalent, there's more knowledge. I had the opportunity to go to Thailand. I learned a lot of dengue from Thailand, came back to Sri Lanka, and then had to tackle learning more dengue. And as a result, I ended up becoming an expert in dengue. I started my own center for clinical management of dengue. And actually, once we had a meeting, at that meeting that we were discussing about the case fatality rate, or the mortality rate between the adults and children. And in an argument, when I said that the case fatality rate of adults were high, then the physicians were telling that it is because it is a different disease in adults compared to children. I said no. And then when I went to this present place, I started a center which could handle both children and adults. Currently, though I'm a pediatrician, I treat more adults than children with dengue. And Dr. Dinusha, who is here, is now a psychiatrist. He worked in my unit some time ago. And we managed to kind of have the lowest case fatality rate for dengue in the world. Currently, it is less than 0.1%, which was 2.3% to begin with. Over 5 years, we were able to bring it down. I was invited to be a co-author for the WHO dengue guidelines in 2011. So that is all what I'm trying to tell is that learning medicine, practicing medicine, teaching medicine, that we all have to do these things with a passion, with a liking. Same thing about learning a language. Learning a language, using a language, and teaching a language all need passion. The biggest obstacle I think people have in doing successfully or not, in doing well at an exam or a OET or whatever, is the way they look at it. Whether they like to start developing a liking and doing it. Same thing for the teachers who teach English. I want to show a true story of a passion to teach English in a school setting in Sri Lanka. The story is about a teacher teacher in English in a very rural school. You know, in Sri Lanka, English is a second language. So most of your school education is done using the mother tongue Sinhala, and then you're taught English in school. And at the GC O-level examination, 52% of all students fail in English. But in one school, there is 100% pass rate. In a very, very rural school, in a village setting, 100% pass rate, and there's no ordinary passes. Everybody has a credit A or B. So that's because there's one teacher who has just developed a passion. You know what he does? In this school, normally school starts at 7:30 in the morning, but the teacher starts teaching English at 5 a.m. in the morning. He comes by his motorcycle to 5 a.m., has been doing that for the last 13 years. He has been awarded national awards for his achievements. He comes to the school at 5 a.m. He inspired the school children to come at 5 a.m. to school to learn English. I mean, that's not by forcing them. They just started liking. And as a result, that school has done better than any school in Sri Lanka in the O-levels in English. So this is the teacher, this is his story. Just wait.
කුරුණෑගලින් කිලෝමීටර් ගාණක් ඇතුළට වන්න පිටලා තියෙන ඒ වගේම ඉතාම දුෂ්කර ගමනකින් පස්සේ ළඟාවෙන
just see how the students the teacher comes to school in the morning.
අහිංසක දරුවන්ගේ දෙමව්පියන්ගේ ජීවන කතන්දරය නම් ඒ තරම් සුන්දර නැහැ. බොහෝ දෙනෙක් ජීවත් වන්නේ දවසේ කුලියට වැඩ කරලා.
These are very poor village where their income is very low.
අවුරුදු 15කට ඉස්සලා මේ පාසලට ආපු ඉංග්‍රීසි ගුරුවරයා විල්බර්ට් රණසිංහ මහත්තයා මේ දරුවන්ට කියලා දුන්නා. මේ හරි පුදුම ඉස්කෝලේ ඉන්න දරුවන් දැන් ඉතා උදේ පාන්දර නැගිටලා කුළුවාතු පත්තු කරගෙන බඩට ලුණු කැඳවත්
This is how he goes to school in the morning.
දරුවන්ට සිප් සතර කියා දෙන
This is the teacher. You can see students come at 5 o'clock to learn English.
මෙන්න මේ විදියට
දැන් අවුරුදු 13ක් තිස්සේ මේ පාන්දර පන්ති අපි පාන්දර 5ට පටන් ගන්නවා.
He's doing for the last 13 years.
අද මේ පාසල
This is student. I mean, their pronunciation is not wonderful, but see.
We want English to do everything. It means if we want to go to a job also, we want English, and for everything we want English. I want to become an English teacher. For that one also I want English. After going to a campus also, we want English to learn everything. when we talk about the children of the other schools, they are thinking that it is not easy for them, and they are somewhat afraid of English also. But we are not like that, as we have very good English knowledge because of my lovely English sir.
When I say something about the English language, it is the children of the other schools are thinking that it is a very difficult subject, but the children of my school are thinking that it is a very easy subject. That's why the students of my school can speak English.
When I talk about him, he is a god for us, because sometimes he is like a father, sometimes he is like a friend. Like that we are staying in the school, and now because of him many children went to good position.
So that is what he's done with his passion. Then I also want to draw your attention to this article that was published in 2016. That said that the third commonest cause of death in the US is medical error. I'm sure this is the same thing for the whole world. That is, in US, as much as 250,000 people die as a result of coming to hospital. And when it comes to communication, the clinical communication failures are considered the leading cause of medical errors. Minimizing communication problems among clinical team members could directly reduce medical errors and hence increase patient safety and improve health care quality. I mean, if you say language is medicine's most essential technology. Language has been described as medicine's most essential technology, the principal instrument for conducting its work. It has been observed that without language, the work of a physician and a veterinarian would be nearly identical. Right. The US Joint Commission states that communication is a core component, not simply an adjunct or facilitator of healthcare. In my SLCP, I said that make best pediatric management to all our children a reality. Communication skills involve both style and content. All doctors are not the same. If you really look at it, the doctors who are doing better are people who have communication at the heart and know the art. Of course, you know, it is, I would not talk much about it because this has been told previously, but I want to just show a slide or two from a presentation I did a few days back in the congress that I completed just few days ago. This was my presentation on the 14th, where my talk was about why do patients die in dengue. I showed that in 2009 we had 35,000 cases and 346 deaths, and 2017 170,000 cases and 400 deaths. This shows a big reduction, but still, I also said that in those deaths also, I'm in the National Review Committee where I looked at the deaths, and he said out of the 400 dengue deaths that occurred this year, we could have avoided more than 360. And actually we would have had only 40 deaths and not 400. This is true for any disease, any part of the world when it comes to medicine. And in that, I want to draw your attention to one other aspect that we did not discuss, that is about not asking for help. True enough that we need to communicate with the patient, we need to communicate with our team, then most of the time, there are many instances where patients die because a doctor failed to get somebody else's other opinion. When you are in difficulty, that you really need to communicate with somebody who knows and ask for help. The real difficult case, better ask someone who knows better. This means that you have to, one reason is that you have an ego. Some Indian speaker who's talked about ego said that ego is expelling the God out. All of us have a God inside, and when your ego is that you have expelled the God out. So because of that, you really don't want to come down to ask. And I want to end this by showing a presentation. This is Professor Suchitra, from whom I learned most of my dengue. She's 85 years, and she's the person who named dengue as dengue hemorrhagic fever. And she said there are 4 successful treatments for the management of dengue hemorrhagic fever, and also for any disease. One, that she named it as 4 H's. One is, she said, that you have to have a head, which means that you need to have a good knowledge, natural history of the disease. You also need to have hands, that is, you need to have experience of seeing and managing a large number of patients. Then you have to have a heart, that you should have dedication, devotion, and regular assessment. then you also need to know, not hesitate to ask help when you are in doubt. Now, to do that, you need the best communication skills, because sometimes asking somebody is just sharing the blame. You have a patient whom you have brought up to the end, and now this patient is going to die. You ask somebody, not with the good intention, but just to share the blame. I asked so-and-so also managed, and so that. But you really need to go to develop your soft skills a lot in trying to develop that, how to ask help. Because whenever you have a patient, when you're treating a patient, when the desired effect is not there, you have to review the diagnosis, which means you may be treating something that you do not really know. And I actually did a study as a junior doctor, looking at postmortems, and found that 50% of the time, when the postmortems were done, the cause of death was not in the differential diagnosis. That is, that the patient died of something that you never treated for. So what do you think OET should do? OET should try and creating a passion, both in the teachers as well as in the students, one of its key objectives, so that it'll have a big success story. They should just see that you could tell all these healthcare workers, this is to help you, not to pass the exam and get a job, but to practice what you have to do and to give the best care that you want to give. Thank you.
We're now moving to a panel session, and I'll just give these people microphones to share. And I have a couple of questions to start the ball rolling, and then we will take your questions. So firstly, a question to Dr. Martin. OET is not just about gaining proof of proficiency for registration. It's the beginning of the journey of continuous communication skill development. Can you give us some insights into how health professionals from overseas can continue to develop their communication skills in the interest of patient safety?
Thank you. I think there's a few ways you could think about that. So I'll do the one that I think is most underutilised first, which is to embrace communication skills teaching in the workplace, which is at the minute sadly very lacking. So we spend a lot of time talking about pharmacology and knowledge and technical skills, but rarely when we're in the environment that we all work in do we focus on communication. So I think that's a massive untapped resource. And in fact, just last week in partnership with the Cancer Council, we ran a day thinking about how we can teach communication in our clinical settings. So that's the first thing. Second thing is I think we should have some evidence-based courses rather than just things that are convenient, which is sadly a lot of the time. And I think we need to build capacity. And lastly, I think we need to train the existing workforce so they can have the same conversation using the same language and vocabulary. So just the way we can talk about anatomy or physiology, we can actually talk about communication between the junior clinicians and their senior clinicians, because at the minute the theory-practice gap, that means when they go into practice they can actually go backwards rather than forwards. Right. So that's my short response to your question. Thank you very much.
There are a few sub-issues in that. We might take some questions in a minute. A question for Dr. Ismail. Attaining English proficiency is obviously vital for patient safety in English-speaking countries. Can you tell us more about, from your JCI perspective, the need for English-speaking healthcare professionals in countries where English is a secondary language?
Absolutely, because in fact in many of the countries, English is the official language for medicine and for practicing medicine. and we receive the patients, we receive the providers from many, many countries. So the level of English in their education definitely varies from country to country. So when this proficiency is actually leveled and tested, I think it is very, very important in order to ensure that they have the minimum that guarantee that the communication is done properly. And if this is happening, it ensures that a lot of issues can be avoided that can create the hazard to safety, as we discussed in the presentation. So the language is absolutely a cornerstone here in order to create the dialogue, in order to communicate with the other providers, in order to communicate with the families, and the proficiency and the mastery of the language here is going to be, I would say, the main tool for this. So I can't explain, how important it is, because everything, as we mentioned in patient safety, really depends on this communication and on this.
Okay, thanks, Dr. Ismail. And now a question to Dr. LakKumar. I think that microphone might still be on. Following on the point made by Dr. Ismail, can you give us some examples specifically from Sri Lanka where English proficiency is proving to be really important in the medical practice of medicine?
Well, of course, in Sri Lanka, the case notes, all the hospital records, both by the nurses, all staff, and doctors is in English. We have been actually under the British up to 1948. So our hospital system is British-based. And as a result, whatever the degree of proficiency people have in English, all the medical curriculum, that is the teaching of medicine in all the medical schools, is essentially only in English. Right. Then the nursing is both English and Sinhalese, but all the notes, even by the nurses as well as by the doctors, in all the case notes, it has to be in English. You hardly could write anything. So there we have an advantage. That's probably one of the reasons why some of the Sri Lankan doctors who are coming and working in this part of the world may be doing better, because they have been brought up to make notes and so on only in English.
So basically, my interpretation of that is English is the lingua franca for medicine in Sri Lanka, definitely. Okay. Question for Gad Lim. As an expert in the field of language testing and someone who has an in-depth knowledge of OET, do you think ESP tests are more likely to protect patient safety than perhaps a general or academic test?
Well, I should like to hope so. I think the thing we're trying to get at in the field of language testing in the last couple of years has really been, to try to test language as similarly and as closely as it is to the language that people will actually be using. And in this particular case, since we're talking about the healthcare setting, the OET is as close as we are compared to most of the other things that are out there, and to the extent that we are able to sample the type of language they're able to use in that context, we have a greater sense of confidence that they're actually able to use that language once they're actually out there.
Sure. Thank you. Question for Sujata. In terms of the big picture, what are your plans for the future to further cement the OET's role in patient safety on a more global setting?
Thanks, Alan. And yes, I think it's very much picking up from Dr. LakKumar's presentation just a few minutes earlier. I think our mission is very much, we are very passionate about healthcare communication and the role of healthcare communication in patient safety and quality of care. And in fact, this forum today, where patient safety and quality of care and role of communication is a key theme of this conference. So this is very much our, our step towards actually providing greater advocacy and thought leadership in this area. And like I mentioned earlier in the day today in my opening presentation, OET actually has a very unique proposition, similar to what GAT says, is the only English language test which actually available internationally, which actually reflects communication as in a healthcare workplace. And we know that there's a huge dependency on overseas trained healthcare professionals in countries not only in Australia, but North America, UK, where OET could actually add great value. But similarly, I think as we were talking to Dr. Ashraf yesterday, in Middle Eastern countries where you have nationalities from, multiple nationalities, both as patients and also as healthcare practitioners, where English is the lingua franca, so where OET can actually play an important role out there actually in improving communication, quality of care, and enhancing patient safety. So from an OET point of view, our mission is very much to, make sure that OET actually moves beyond the Australian shores. We've already done that with the recognition in the UK, but further on perhaps in Ireland, North America, and other countries where OET could actually add value in terms of improving communication skills in the healthcare sector. And of course, our mission is to work with other organizations like JCI and Deakin University who actually have a similar mission and similar objective.
Yeah. I think that partnership point is a good one. Ladies and gentlemen, it's now over to your questions, the ones you've suppressed in the morning or have been waiting for. Here's your chance. And don't forget to put your hand up so we can get a microphone to you. Question over here in the centre.
I've just got one question really about OET compared with IELTS, because my feeling just from the experience really since last year is that OET is much better preparation for working in the health field than IELTS. Do you think that OET will eventually become the preferred testing method and will become always a requirement for the health professions, and IELTS will be less important?
It's a difficult question for us to answer because the decision on what English language tests are going to be used for healthcare registration is often a decision made by the registration boards and councils and not by us. And but however, I think yes, your point. I take your point that OET actually is OET and IELTS. I think it's not about which is better and which is less better, but it's all about the appropriacy of how the test is being used in what context. And from that point of view, I think IELTS is a fantastic test for tertiary education for the purpose it is designed, whereas OET actually is specifically designed for healthcare communication in partnership with healthcare practitioners. So from that point of view, what we see is the feedback that we receive from candidates is that they do prefer OET for two reasons. One is they find the content very familiar, so that gives them a sense of confidence on test day. And the second feedback we often receive is that they feel that preparing for OET actually has a good impact, a good washback effect, because they do pick up language skills that actually help them in terms of success in their career. For example, we had a nurse from India that we interviewed. She said that when she worked in Australia, she understood the importance of showing empathy, but didn't know how to, and preparing for OET helped her. So I think from that point of view, I think it's a question more for the regulators, and they make a decision on what exams to be actually used for registration purpose.
Thank you.
I can add to what you say. I mean, I have the experience of coming to the UK, having got through my IELTS. But during that time, this was in the late 1990s. Communication was not considered a very important component of any of our exams. Now, of course, for MRCP, for MRCP-CH, everything there is communication is one of the primarily important things. So that we all have in our exams, in the local exam, there's a separate communication station, so that it is tested. That you cannot get through a postgraduate exam without being proficient in your communication skills. And most of the time, it is tested in many, many repeated places. Those days, even in the UK, that was not a component. I would personally think from a pediatrician's or a physician's point of view, maybe not so much for the surgeons and the other people who might be talking less, but I think it should be the case for them also, that if you learn English and get through the OET, that you are learning two things. It's not only English, you also learn something that is needed to practice medicine compared to what I came with the UK. So I think definitely for a healthcare manager to select people who are either IELTS qualified or OET qualified, if somebody's go for people who got through OET, you cannot complain about it.
Okay. There was a user's perspective, someone who employs medical graduates. Other questions from the floor? There's one going over here, and then you, Alicia.
Just talking about patient safety, it's fairly terrifying when you come up with some of those statistics. And I just wondered how much of this is about language and communication and how much of it it's about systems management, leadership and setting up of standards, so that when you cross over from doing an OET test and actually working in an environment where you have to communicate, that there aren't better systems in place so that these statistics are not so horrifying, and so these people are supported once they get in those workplaces to continue and improve and to make that communication more effective to bring down those statistics.
Good question.
So where does management and systems sit in here?
Peter, would you like to make a start on that one?
I'll try my best. So I think there is a tension between relying solely on systems and, if you like, the leadership, both the clinical leadership and the leadership of the organisations. I think there's been an over-reliance, as I mentioned earlier, on process and systems and not giving the people the professional development opportunities to be able to use those systems and processes. So if you think of clinical handover, there's been a lot of emphasis on the systems and processes of handover, but not of the skills on inter or intra-professional communication. And I think the leadership up until fairly recently maybe didn't have their head completely in the sand, but it was certainly going that direction at times, and I think that's finally changing. I think for the first time now I'm seeing CEOs and executive boards and boards that oversee the executives all saying that communication is a core part of what we do, not communication processes, communication skills. And I mentioned that issue of skill acquisition earlier, but of course now we need to actually start doing something about it so people can acquire those skills right across. And particularly I think the interprofessional and intra-professional, that's been probably underinvested in and really needs to grow. So that's my initial take on your reflections. And I think you're right, it should be terrifying. If this was hand washing or something, people would quite rightly be up in arms. They should also be up in arms about giving people the opportunity to improve this. So I think when you see statistics like that, something that's so preventable, if you like, we should be militant in how we go about changing it.
Well, there's a call to action. Militancy in the medical profession to reduce patient error arising from communication. Before we take one more question, Alicia first and then the lady there. I was just going to ask Dr. Ismail, in terms of that question about moving from OET skills to the systems that they find in the hospital which support them, any findings that come out of the JCI support that?
There is no specific standards that support that. We didn't mention specifically a specific test to be that, but the requirements for considering the language of the patient and respecting the language of the patient, the culture is a requirement.
Okay.
So we didn't specify how we do this, but it definitely is a requirement.
Okay. Well, that's a framework. Anyone else want a particular comment? Otherwise, I'll move on to other questions because we've got a few. Alicia, you were next.
Yes, this question is for Dr. Ismail. In your protocol for, or your standards for communication in accreditation, was there any mention or any thought to official translators? when it comes to language barriers, because I do recall from reading up that especially in the United States of America, they do have medical translators that they call on sometimes in specific hospitals. What is the panel's ideas and thoughts on official medical translators in hospitals?
You mean the medical translators to translate to the patients? Yes, there are requirements for translators is to be educated and about the medical terminology and to be also licensed, to be identified and licensed, and like to be neutral, not on the side of the patient or the side of the hospital, and to satisfy the different languages. Actually, it is, if they are not speaking English and they speak other languages, is to have those in different languages. So if this is your question related to this, also it is required during the survey in a country like maybe countries where they do not speak English, is also to have translators who are identified and legal translators also to help during the surveys in order to make sure that we communicate with the patients and to get their perspective during the survey as well. So it is a requirement.
Okay. Does anyone else want to make any comment? And then we've got a lady in the centre here, I think.
I think one of the challenges is in major metro hospitals here, for instance in Melbourne, they're actually paid full, permanent staff members who are medical interpreters or medical translators. We do know that not everything they're given they translate exactly as we'd want, but still it's a big step forward from what. And I think there's an increasing improvement in the access to at least having a telephone. I think when you go out into regional and certainly rural settings, this becomes a much bigger challenge. And I think people just take sometimes the soft option and sometimes use their carers, which the variability, as we know, is quite dramatic. I've had personal situations where somebody's turned up for a cancer complication, not knowing they've got cancer, and because the family members find it too painful to tell their loved one that they've got cancer, and you somehow find yourself 6 months down the track trying to explain a problem to them that actually, well, they don't even know their diagnosis. So, there are massive ramifications for everybody involved, and I think we need to improve it a lot. It has improved, but I think we have a way to go, certainly here in Australia.
Lady over here,
yeah. More of a comment. Those issues notwithstanding, and of course they're so important, but I've long thought that it's incumbent or should be incumbent on native speaking staff to work harder to understand people, to communicate better with people who come from a non-English speaking background. It's almost like the English learners are always the problem and everybody else is okay. And I think native speakers need to work harder. So the exciting thing to me today has been this organisational approach, which I've never heard before in relation to healthcare communication. At last, thank goodness. Yeah.
Can I just add a comment before we get the next question? Having had a personal experience at one step removed of a failure in medical communication in our immediate family, just an interesting observation, there are nuances to successful medical communication. It's not a binary situation, which I think you're making that point. But the nuance that was clear in our family was that there were differential levels of clear medical communication from different practitioners in the process. The best medical communicator was the charge nurse in charge of the ICU. The paediatric cardiologist was very good. The worst was the surgeon. And the charge nurse said, quote unquote, to my daughter, who is a medical research and therefore an educated questioning parent, said, "Don't worry, you won't get an answer from the surgeon, but I think I can decode what he meant to say." Now that's the nuance that you find in the medical profession. And I think Peter's sort of shrugging sheepishly, but acknowledging that that's what happens in some hospitals.
I'll still acknowledge a long way to go, but I think it's the first time I've seen a genuine tipping point at policy level, at kind of government level, college level, at board and CEO level. It's the first time I've seen it truly line up. That doesn't mean we're there yet. And one of the reasons I think we've got Jetta coming out from Denmark in the near future is what happens when you've been doing this for 10 years. Because I think people need to know, if we make this investment, what are the returns, what starts happening in your organisation, because I think they kind of do it at one level, but well, what are we going to get back from it? Because it's not without investment to get this right. We're not quite there at the organisation level, but it's starting. People are starting to talk about it. Even in the last 6 months, I've had 3 different hospitals in Melbourne here saying we're actually starting to focus on this. And you know, that just wasn't happening 5 or 10 years ago.
That's very encouraging. I think Sujata wanted to make a brief comment.
Yeah, I think just a perspective from the English language teaching and testing point of view, because one of the assumptions in English language testing and teaching, which Gat perhaps can talk a bit more than I can, is that when you're teaching somebody to actually communicate in English and go and work in English-speaking country, the assumption is that you'll automatically speak to a native speaker. But however, if you look at countries like UK, Australia, New Zealand, it could be actually one nationality speaking to another nationality, and for neither of us, neither for the patient nor for the healthcare practitioner, actually English is the first language. And I know there's a lot of research. I know I was talking to Professor Tim McNamara. He said that there's a lot of research going on in this area. So how do you actually adapt your teaching and your testing where 2 non-native speakers are communicating, which actually is a reality in most multicultural countries these days. So there's an interesting kind of shift in how you teach and how you test.
And again, it's reinforcing the point that English is the lingua franca. Forget who is actually producing it. It's the language which is the link. Yeah. There was another question. A gentleman there. Yes, thank you.
Hello there. This question might be suitable for Peter Martin, or I'm not fussed who answers it. But I was looking at those figures before, 70%, in some cases 80% of medical misadventure, if you like, related to poor communication. How much of that would be related to lack of English skills, and how much of that would be related to a culture of not questioning people in positions of authority?
Can you repeat that question?
So the question, it's sometimes difficult to pick up, was when we look at these high statistics for medical misadventure, which of them are caused simply by language and which could be caused by cultural issues as well? Have I captured it? Okay.
I'll go first. I think your last point about the authority is the one I'll address first, and then we'll see what Ashraf wants to contribute. I think actually you're right, we're still in a quite old-fashioned hierarchical system where there could be medical misadventure, which is a strange term in its own right, so I'll leave that alone, because people don't feel they can advocate to do the right thing for the person they're concerned about. And so in fact, I've just been running pilot sessions this year with our final year students when they're really thinking about how are they going to advocate for their patient when there may not be somebody who's terribly receptive at the far end, whether that's in another part of the hospital, whether they have to do it at 3 o'clock in the morning to the grumpy consultant, whatever it has to be. But how do they escalate their concern because their primary responsibility is to the patient? And it is not a straightforward skill. And unfortunately, I do think a proportion of these misadventures are because of this authority and hierarchy and the skills that we do not equip them with to be able to advocate for the people they're responsible for. I can't give you a figure, and I'm not sure that I know that it's well studied, and it should be, but I'm not sure if Ashraf's got some idea. And so to break it down might be difficult, but I think it's part of the problem.
Ashraf, would you like to add anything to?
No, thank you. No.
And I think just drawing upon a kind of parallel industry, which is also highly regulated as the aviation industry, I think there have been research where it's not just language and communication, but culture as well.
Yes.
For example, the famous, I think, a South American airline which crashed in New York, where when they got the black box, they realized actually that they knew what was wrong, but out of respect, you don't challenge your captain.
They didn't challenge
the first
the captain.
engineer doesn't challenge your captain.
Yep.
And that's where I think a lot of South American airlines and East Asian airlines actually work in changing the culture where you can question and you can challenge. So I think that's a really good question, because in many industries you find culture actually stops people from challenging when you think somebody who's your senior is making a mistake.
And I think it's compounded by the fact that we all defer to hierarchy. And in the medical profession and in many professions, there is a hierarchy, and some people live and breathe their role in the hierarchy, like your lecturer in paediatrics.
Can I just add in, one of the things, the analogies I use for the students is that there is good research that if you encourage and empower your junior clinicians to challenge the senior ones, you get better health outcomes for your patients. So that there is some research around that. And the other thing I talked to them about is, I'm not sure if this is still true, but in the submarine industry, the executive officer deliberately questions the captain because by the time you've sunk the boat, it's a bit late. So the idea is that they challenge it rather than say, it's too late, I've written up that drug or I've given that drug. You say, are you sure that's the right dose? Are you sure that's the right drug? So, I think changing the culture of how we do business, where our primary focus is our patient, where we say, challenge me. And actually it's really useful because you say, Peter, can you tell me why you chose that drug? I'm not clear. Are you sure it's that dose? And the reality is, of course, all of us make mistakes and we rely on a team culture to minimize those mistakes.
Other questions? Yes, go ahead. Can you take the microphone a bit closer?
Oh, thank you. Just a greater intention from communication and trying to sort of transform the healthcare system as well, where much of that responsibility for healthcare is back with the individual, so out of the institutions, and talking about self-management more sort of from, I guess, an operational point of view rather than sitting in policy. Is communication and better communication part of that goal as well? The better we get at it, the better the patient or the individual will become at it as well to take care of their health. Any opinions on that?
Can I just put rephrase your question for the benefit of some of the panellists when to capture it? I think you're also asking a question about moving patients from a passive role to an active role in the communication. That is giving them some self-confidence to ask professionals questions. Just as there's a hierarchy in the medical profession, many patients are excessively deferential towards medical and healthcare providers. And what I think you're talking about is, what do we do in the ecosystem to encourage patients to speak up in a constructive way? Is that what?
Absolutely, because it's still sitting just, I guess, you read a lot of it in that policy and procedures again, and how do we actually operationalize that in skills for our patients as well?
Sure. Anyone got any observations on?
Absolutely, and I think empowering patient has been proved to be like one of the main factors in the success of the outcomes of care, and giving the knowledge to the patient, explaining to the patient about the condition, about their chances of choices, about the procedure that they are going to have, and all this information make the patient really empowered and encouraged to speak up. Actually, this is an initiative that even the Joint Commission has started, is to encourage speaking up and to avoid the culture of fear. There is inherited culture actually between the physicians and the patient. In many cultures that the physician speak, the patient listen, and there is no discussions or there is no choices. So now actually the culture of safety, which is a basis of all patient safety and the high reliability and everything, emphasizes the importance of educating the patient, empowering the patient, giving the knowledge to the patient and the family, by the way, because sometimes the patient cannot make it for himself or herself. So the family here need to be involved in this as well. Is very important factor, and it becomes a standard. It is not something to do or not to do. It is a requirement in the standards as well, is to have the patient education, to document it, and at all levels of care during the stay and also at discharge, so the patient would leave the hospital with full information, powered with, about the medication, about the follow-up, about everything, so that they would know what to do after leaving the hospital. So it is absolutely important, absolutely required.
Okay. It is actually a case of extending the team to the patient. You know, the successful medical care is all teamwork. Even the problems, the gaps between the hierarchy and the others is also about a deficiency in the team. I know that the problems that I had when I was a junior doctor with the hierarchy, I don't want that to be there with myself dealing with my juniors. Because it's good always if a team discuss, explore all possibilities and do. So when somebody questions your superior, leadership is one. Leadership is a person who will deal with a team. But a good leader should have access to every member of the team, both big and small. We need to develop a culture to involve the patient into our team that manage the clinical condition, so that he is also part of it. That we most of the time respect his views, ask him, explain to him, get his opinion also to a certain extent while explaining, so that everything is done by an agreed team. In my management of critically ill dengue patients, I give a little bit of a responsibility of monitoring the patient to the patient's, because bystander, parent or something. I'll tell what the parameters that you would want, the blood pressure, pulse, so on, that should be there, the urine output that should be there on a monitor, and tell them the value of monitoring them in addition to the nurses and other people monitoring them. So they also could tell when things are not moving in the correct direction, that you can always get the patient to be involved in the team, that you have to extend the team culture to incorporate the patient into the team, then it becomes easy.
Great. Thanks, it was a good question. We've got about time for maybe 2 questions. Any more questions?
Can I just add about the self-management? I think everybody would acknowledge that we need to change the culture to maximise self-management. And of course, the global epidemic of diabetes were a major piece of this literature. You know, they were some of the pioneers in thinking about, are we really maximising the expertise of the person with the illness and who has the lived experience? And so I think they have been really, generating a lot of the body of evidence, and of course everybody realised we should be thinking about that as well. So I think that because of what's happened with diabetes and our global epidemic, I think that the idea of how we maximise self-management and how we get the clinicians to empower the patients to self-manage is a brand new direction that the graduates are being taught about that previously they weren't. So it's a culture change. It's going to take time, and I back all my colleagues' comments. But I actually think, interesting that I think that illness alone has given us a framework to really challenge ourselves.
Can I make an observation that I think there is, retrospectively almost, an improvement in the medical profession from my very limited sample, that my own GP, who is a woman in mid-career, she's probably 45, I've detected in the last couple of years that she now asks me far more questions than she tells me answers. And when I told her, I'd actually seen some of the OET interventions, and I joked and I said, "Oh, have you done some recent professional development on patient communication?" And she roared laughing and she said, "You've caught me out," because she had done something and it literally had changed her focus. So instead of from telling and sort of instructing that this is what you need to do, we had a dialogue and we reached an agreement on what the outcomes were. And so there's a mid-career professional who's made a change, so it's possible.
Hallelujah, I can't say that.
So this is the point. The system may have a lot of things in it that need changing, but my reason for telling the positive story is it is quite possible to change, because it's a series of individuals make the change, and she's in a practice of 14 GPs. So clearly that will cascade through that group. Other questions? Yes.
Yeah, this question could be to anyone, I guess, on the panel, but when you're teaching communication skills to the doctors or health professionals in the hospital, do you distinguish between those that are native speakers and those who perhaps are non-native speakers? In other words, if they're native speakers, perhaps only need the theory behind how they communicate effectively with the patient, but if they're non-native speakers, they may need more grammatical structures in place and more a more language framework approach.
So I'll take this and then my colleague can add. We don't differentiate anybody who's willing or able to come along to a professional development. We offer them the opportunity. We've got quite a wide mixture of international medical graduates, some of whom English will not be their first language. Do I think I have the skills or the knowledge about the linguistics? I don't. Do I think some of the core process skills are exactly the same and then they might need to pay particular attention to some things? I do. If they needed something beyond that, I guess it's a good question. I mean, where would I kind of send them to do that in partnership? And that's something that maybe needs a bit more exploration. I haven't thought about that as much as I should. But do we differentiate? Absolutely not. There is a sense that some of the people who've been identified as struggling, sometimes I think they're international medical graduates and they're struggling, for instance, to pass exams. And are we always clear about what's language and what's comm skills? And I think they blur together. That's the other issue. They're quite blurred at some point.
I think for us, Steve, from an OET point of view, I think, which I think David will speak later about, I think it's very much kind of, irrespective of what your first language is very much kind of encouraging self-diagnosis in terms of what are the development skills I need in terms of, let's say, OET to get the required grades in OET. Is it my basic English in terms of grammar and pronunciation and vocabulary I need to prepare? Or is it in terms of preparation, the test preparation? So I think irrespective of what your first language and nationality is, I think it's basically understanding where your areas of weaknesses are and focusing on those. Typically in my, over 15 years of working in language assessment, what you find is with native speakers, often you come and take a test unprepared, and then you don't get the required score and you get surprised, because at the end of the day, a test is an artificial environment where you are required to reproduce your skills in a timed circumstance. So you have to be able to, I think preparation is very important. So it's either understanding what to expect in the test, or from a second point of view, from, do you have the basic language skills to reproduce on the test day?
So I guess it just seems there's a place, in my opinion, as an English language teacher, to have some specialist language teachers there that actually give structure. Because if I read a lot of books on medical communication designed for native speakers, it's all theoretical, and I just feel there's a bit of a gap that's not going to meet the needs of all language learners, even if they are quite at an advanced level, there still may be a place.
I think the summary of what you're saying is there's a broad spectrum of language skills from competent and just managing to get communication across the line to highly sophisticated, and we need some differentiation in there. I think the answer that Peter would give, if I'm not putting words in his mouth, is let's get everybody across the line in terms of effective communication at a reasonable level, and we can put the sophisticated levels in later.
Maybe the thing you're saying is that we haven't worked out how to bridge as well as we should, that it's not one or other, it's how we work together, and that really does need some more thought. I would agree, because I think it's such a key part of what happens to our community, and frankly the stress that puts on those health professionals when they feel they're not performing at their best. So I agree. I think there's some bridging work that is yet to be done that we need some thought about.
And it sounds like there's a fair bit of research yet to be done to identify the real areas for focus, Peter. Yeah. Ladies and gentlemen, one more question on the far table. Sorry, can you wait till you get the microphone?
Yeah. My question is, in fact, I would like to throw light on the 12 medical professionals that we have included in OET. They take OET test. Are we going to stick with those 12 professions? I'm especially talking about social workers. They deal with the patients as well. So would it be any test for them? I don't know the structure like,
At the moment, there are no plans, but having said that, it doesn't mean that it's never, because we review our strategy, we review the demand for the different professions, and if there is a demand for OET specific to social workers, absolutely. Because as an organization, we try to be very responsive, and where there is a demand, we will try to put the tests. So at the moment, there are 12 professions, but having said that, there's nothing to say that we won't increase that in the future, should there be a requirement.
Good for everyone, I mean, sometimes we feel, I don't remember, but I did receive call it was in India. I did receive call. I don't remember exactly what was the profession, he had. And he asked me, okay, can I take OET test? And just I searched the list. No, you can't take OET test. I don't remember what was that, but
At the moment, what happens actually is, for example, the Chinese Medicine Board of Australia, they actually recognize OET. But however, we don't really have a Chinese medicine specific OET, so they actually just specify you can take any OET. And typically what we find is they take either the medicine or the nursing, because the reading and listening part of OET is common to all the 12 professions, is healthcare specific but not biased towards any particular profession. Whereas speaking and writing is profession specific, but we do find a lot of Chinese medicine specialists taking nursing or medicine part of OET. And having said that, I'm actually going to be in Ireland next week, and I am meeting CORU, which is the allied health professionals who also manage social workers, regulates the social worker profession in Ireland. And you never know, based on the discussion, you never know what comes up. Barbara's looking worried out there. Thank you.
Okay, ladies and gentlemen, with that question, I think we'll end the Q&A now. There is another Q&A session after we do our little triumvirate of short presentations after afternoon tea. We're breaking now for afternoon tea. We want to resume exactly at 3:30 so we can keep to time for the rest of the day. Thanks very much for your cooperation.